Division of Haematology, Oncology at SickKids. Welcome to the third in our series, specially targeted education program, Building COVID Vaccine Confidence by Educating the Educators. This program is being delivered in collaboration with the SickKids Learning Institute, the Black Creek Community Health Center, the Black Physicians Associations of Ontario, and the Scarborough Health Network, VaxFATS. Thank you for attending. Today, our session is a workshop entitled COVID-19 Vaccines Pediatric Focused Workshop. We will begin with a land acknowledgement. We would like to begin by acknowledging the land on which SickKids operates. For thousands of years, it has been the traditional land of the Huron-Wendat and the Petun First Nations, the Seneca, and most recently, the Mississaugas of Credit River. Today, Toronto is home to Indigenous peoples from across Turtle Island, and SickKids is committed to working towards new relationships that include First Nations, Inuit, and Métis people, and is grateful for the opportunity to share this land in caring for children and their families. And we want to remember today that today is November 11th for all the people who have sacrificed to make sure that we have the freedoms that we enjoy. So today is Poppy Day, and it's a day of remembrance. Our session this afternoon will be in two parts. The first will be two 20-minute presentations on specific topics relating to pediatric COVID vaccine administration. Then this will be followed by a 30-minute workshop, and we've lined up a group of experts in the pediatric field to be able to answer questions and be able to share their expertise. So let us begin with the first, which will be given by Dr. Upton Allen, and the topic will be the science balancing efficacy, effectiveness, and safety through the lens of the regulator. Dr. Upton Allen will introduce himself before he begins his presentation.
Thank you very much, Isaac. I'm Upton Allen. I'm head of infectious diseases at SickKids and a professor at the University of Toronto, senior associate scientist within the Research Institute at SickKids. My focus today is really to information share with you, to speak to the issue of balancing benefits versus risks as they relate to the COVID vaccines, specifically the mRNA vaccines. And near the end, I'll also get into some practical issues relating to vaccinating children. And I do look forward to the subsequent presentation by Dr. Taddio, which we all look forward to. Now, vaccination is all about benefits versus risks. And based on a synthesis of the available evidence by regulators such as FDA, it's clear that benefits outweigh risks. But they are risks, and today we just need to acknowledge them, and I'll help to put them in some sort of perspective for you. And so let me start though by talking about some of the benefits, because patients will come to you and they will have questions, and so it's important to be able to put the benefit side of the equation in some sort of a context. So let's talk about the potential impact of COVID on the individual. In that regard, there are three main areas of focus. If we see an increase in the number of cases during the respiratory virus season. So we need to remember that at this point in time between now and about the end of February, we have entered and will go through the respiratory virus season. And the SARS-CoV-2 virus is a respiratory virus. And so it's, hitching a ride on this season. And so it also got a running start into the respiratory virus season. And so we will expect to see increases. And this could potentially impact acute COVID, the multi-system inflammatory syndrome in children, and the potential for long COVID. Now, with respect to the acute COVID, we've seen an increase in the number of cases in children 5 to 11 years over the last several weeks. This has occurred when cases, for the most part, among other age groups have actually decreased. And this is not unexpected because this is what we see as we enter the respiratory virus season. And so the 5 to 11 age group accounts for just over 5% of our COVID cases at the moment. So we need to pay close attention to this. There's a potential of an increase in the number of cases. Now, kids, for the most part, when they get COVID, they get a mild illness, but rarely they can have severe illnesses. And we need to remember that. We also need to remember that there's the potential that the multisystem inflammatory syndrome in children, as rare as it is, could occur. And when it does occur, it can be severe and severe enough to cause mortality. While data are still being gathered on this particular entity, some of the earlier emerging data suggested that there were rates that were highest among individuals of African, Caribbean, Black ancestry. But we also know that besides the multisystem inflammatory syndrome, there are the potential consequences of long COVID. And we really still don't have a good handle on the precise incidence of this entity. But we know that research is continuing. If you look at some data emerging from Italy, there are rates of up to 27%, other places higher. UK is low as 2%, probably settling about 4% at day 28, and about 2% at day 56, compared with adults who have 13% at day 28 and about 5% at day 56. So lower rates of long COVID in the children, but the rates will depend on the duration of follow. So even though the rates of long COVID might be potentially low in children, we still need more data. And indeed, if we have large numbers of children affected, then we will have proportionately larger numbers of long COVID. And these manifestations could be potentially devastating for young kids. Can you imagine a young kid during the prime of their educational life going through periods of brain fog or things that might impair their learning? When you look at some of the manifestations of long COVID entities that have stayed around longer, the disturbance in smell and taste, we see persisting among children, headache, sore throat, fatigue. The darker colors represented the symptoms that actually have a more prolonged stay compared with the lighter colors. So smell and taste, headache, sore throat, and fatigue. But we also know that besides the impact on the individual, there's the impact on disease transmission among individuals at schools, in the home, and in the community. And children can serve as important reservoirs for SARS-CoV-2 transmission. We know that asymptomatic children may shed virus for an average of about 2 weeks. And so there's a potential then for significant exposure and spreading as a result of asymptomatic infection. We also know that individuals who are vaccinated are likely to have lower virus load and therefore perhaps a lower potential for transmission. And so all of the efforts then that are directed at vaccinating kids 5 to 11 would contribute to an overall reduction in SARS-CoV-2 transmission within the home, schools, and community. Now, we can spend more time drilling down on each of those and the consequences, for example, of being able to get kids back into school and keep them there, that we can cover, but we all acknowledge how important that is. Now, in this context, the importance of helping to maintain a safe and effective learning environment. This is another important point that we can all bring out when we counsel families. But we also know that besides the benefits, i.e. the impact on the individual illness, the impact on disease transmission and all the benefits thereof, there are risks, and there's no question that there are risks. So let me walk you through what the FDA looked at in coming up with a decision, and Health Canada is looking at this. When they looked at the lower dose of the Pfizer vaccine, the 10 microgram dose, it was found that that dose provided neutralizing antibody titers that were similar to those titers that were seen when one used doses of 30 micrograms in older individuals. So essentially what we're saying was that the 10 micrograms for the age band 5 to 11 was giving immune responses as far as neutralizing antibody titers that were equivalent to the 30 microgram dose. Therefore, there's no need to use the higher dose. So that's point number one. But number two is that these neutralizing antibodies were effective against the Delta variant, and the level of activity against the Delta variant was reasonably similar to the original activity against the wild type strain of SARS-CoV-2. And overall, when they looked at the vaccine efficacy, it was about 90%. And it is shown here, where in the placebo group, in the clinical trial, the placebo group had 16 cases, the vaccine group, smaller number of cases, efficacy of 90%, lower bound of about 68%, upper bound of 98%. One key point is that the study, as they are really trying to make an effort now with all of these studies, was done in a manner that tried to enhance diversity, to include adequate numbers of Black or African Americans and racialized communities. The proportions are a little bit lower than the original clinical trial, but they're trying, and I think it's an important message that we need to get across, that in the clinical trials we need to continue to speak to the importance of diversity. Now, with respect to safety, safety to date for the Pfizer vaccine was studied in about 3,000 individuals, 5 to 11 years of age, and no major serious side effects have been detected to date, but monitoring is ongoing, and that's important to recognize. But let me show you some of the data that came out of the original phase 1 type studies. And here they looked at local reactions. And if you look at the 30 microgram dose compared with the 10 microgram dose, the 10 microgram dose was producing lower local side effects such as redness and swelling compared with the 30 microgram dose. Pain was perhaps marginally better with the 10 microgram dose. If you look at more systemic events, again, the 30 microgram dose produced more systemic symptoms in terms of fatigue and headache and chills compared with the lower dose. So this is all good. But the big signal, to be frank and be upfront, is myocarditis. And patients will come and they will ask you questions about this. So I'm going to spend some time to talk about this. The first is to appreciate the age bands and the rates at which myocarditis occurs at different age bands throughout the pediatric age group. And here are data from Finland, 2004, 2014. And basically, if you go from the right, essentially what happens for both boys and girls, but certainly dramatically for boys, you can see a decrease in childhood myocarditis as kids get younger. So a decrease in the myocarditis as kids get younger. If you look at the rates of myocarditis pre-COVID in Ontario, these are data from ICES, you also see a decrease in male and female pediatric myocarditis as the kids get younger. So decrease as the kids get younger. And if you break it down into myocarditis versus pericarditis, you see that same trend, a decrease as the kids get younger for myocarditis as well as pericarditis. And so essentially, this is really important because we know that while the rates of myocarditis are higher following the second dose than after the first dose, the highest rates of myocarditis that have been reported following the mRNA vaccines are seen in older individuals. So the age band 18 to 24 would have a higher rate of myocarditis compared with the 12 to 18. And that is pretty more or less consistent with what one would expect of when one looks at myocarditis prior to COVID. The other important point is that it appears that the myocarditis that has been occurring might be dose-related, with data showing significantly higher rates of myocarditis following the Moderna vaccine compared with the Pfizer vaccine. Moderna was dosed at 100 micrograms. Pfizer was dosed out at 30 micrograms of RNA. Data from the USA and the Israelis looking at their surveillance confirm that following the COVID vaccines, the myocarditis rates were peaking in the older individuals with lower rates in the younger individuals. Given that the dose of the mRNA vaccine is also lower in the 5 to 11 age group, I think we have two factors that are coming together here that would make us think that it would be reasonable to predict that if post-vaccine myocarditis occurs in individuals 5 to less than 12, it would be at a very low signal for two reasons. One, the younger age groups see lower rates of myocarditis to begin with, and also they'll be getting a lower dose of the mRNA vaccine. And so I'm going to close with a few practical points. I want to make sure that my time is not too far off. Thanks, Karen, for giving me the 5-minute warning. But let me leave with a few practical points. The first is people will ask, well, what about the vaccine? What's different about a pediatric vaccine compared with the adult vaccine? The pediatric formulation is different, but it's not different in a huge way in terms of the ingredients. The mRNA dose is less. The lipids are the same. The buffer is different. It uses a buffer, tris buffer, which we use a lot in medicine and in research, and instead of the phosphate buffered saline, which we also use a lot in medicine research. So it's well known. It's just a different buffer that is used, and it uses sodium chloride as the injection for the diluent. So it's, the main difference is the buffer. Also, they're color-coded differently. So it's a different formulation. The adult formulation is a purple top. The pediatric formulation, orange top. It's a lower dose. Injection volume, you can see, is different. All of this information we can make available to you. And the storage conditions are also somewhat different as well. Now, one of the questions that comes up is, should children be dosed differently based on their weight? And all we can say is that Health Canada is looking at this very carefully. But if we go with, the science so far, we believe that children should be based on age as opposed to weight. I know that it's certainly worth looking at more closely, but in terms of the maturation of the immune system, it's an age-related factor, not a weight-related factor. And so it's important to bear that in mind. Now, I know that there are many special challenges that are faced when we vaccinate kids in the community, and I'm not going to dwell on these. We perhaps could talk about these in the latter part of today's event. We are going to have to deal with situations where kids are ambivalent, or parents might be ambivalent. Needle phobia, pain. This is where experts like Taddio come in. Unsettling reactions if the kids are crying or screaming. Hopefully they won't, but we have to deal with that. Fainting episodes, as special needs kids, making sure we have the appropriate personnel in terms of staffing and their expertise, and then perhaps in some settings, even security, where some families might feel threatened if there's a lot of protests against vaccines more generally. As I think about this, I often think of the experiences that I've seen in community settings, and here this is just one thought of in a large setting, having an area where some sort of triaging is done that determines whether or not the kids are vaccinated in an open setting type of environment, depending on the resources, and cool down in that type of environment, and similarly, whether or not they should be vaccinated in a smaller structured environment, and then cool down in a smaller structured environment. Having on-site people who are ready to provide pediatric-based counseling, because families will have questions, and so all of that would be needed as one tries to build a practical setting that is child-friendly in several respects, but also takes into account the fact that some kids need a more smaller structured setting, while others are quite good in the open setting. So with that, I'm going to stop, and then I'm happy to take questions during the Q&A segment. Thank you.
Thank you so very much, Upton. Very illuminating. Now we'll move on to the second part of the presentation by Dr. Taddio. She'll be covering vaccinating little ones, strategies to reduce or eliminate pain.
Thank you very much.
Over to you.
Thank you.
And
I'm going to try
a few words about yourself, please.
Oh, sure. I'm a professor in the Faculty of Pharmacy at the University of Toronto and a senior associate scientist at the Hospital for Sick Children. And I work on pain and fear management during procedures and primarily immunization. So it's great to have this opportunity to address all of you. And I think this is a perfect segue from Dr. Allen's presentation. So first off, can everyone see my screen? They can see my title. If you could just let me know, Isaac.
Yes.
Oh, wonderful. Okay, so I'll begin and also wish to acknowledge the land on which the University of Toronto operates. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. And today, this meeting place is still the home to many Indigenous people from across Turtle Island. So what I'm going to do is talk about engaging children in the immunization process, which maybe sounds different from what people normally think is a good idea, promoting coping, and positive vaccination experiences, which together will promote vaccination. So as everyone knows, vaccinations are the most common reason we receive needles, and injection pain is actually the most common adverse event following immunization, or AFI, even though we don't normally acknowledge it as such. The amount of pain that someone feels is subjective. That is, it's an individual experience, and we don't know how it feels for anyone else but ourselves. And importantly, children are more vulnerable to needle pain and negative experiences. Children report more pain and are more bothered by needles. About 2/3 of kids and 1/4 of adults are afraid of needles, mostly because of negative experiences with needles. And being afraid can increase pain as well as increase other immunization stress-related responses. So we've already seen on Dr. Allen's slide things like fainting or maybe feeling dizzy and other adverse events. It can also lead to vaccination delay or refusal, as people avoid things that make them feel anxious or afraid. And across different studies, including kids as well as adults, something like about 1 in 10 people avoid or delay vaccination because of concerns about pain and needle fear. And it doesn't seem like a lot, except that if you're trying to vaccinate everybody, it is a lot. And it's preventable. So why shouldn't we do anything to help with pain when we actually have lots of evidence that we can put into practice right now? And we've been working on this topic for about 3 decades, putting together some of the primary research and then also developing a clinical practice guideline. And the most recent publication was in 2015. And what you see here at the bottom of this slide is a summary of the different categories for which we made recommendations. The first 4 categories from left to right are the types of interventions that you can do to reduce or mitigate pain, fear, and fainting. So procedural interventions, these are things that the immunizer can do, not in the control of the patient. Physical interventions having to do with body positioning and activity, pharmacologic interventions, these are the medications we can use, and then psychological interventions having to do with thoughts and behaviors. And the one on the right, the process interventions, is really about how we get everybody to do the first 4. So I'm going to talk a little bit about all of these things now with a focus on children. So firstly, what are the procedural interventions that can make injections less painful and less fearful? As I said, these are things that immunizers can apply for all their injections, for all the patients, no matter how old the patients are. The first thing is, which is a standard of practice or care in Canada, is not to aspirate prior to injection. So this does add a lot of tissue trauma and a lot of pain to the procedure and isn't a necessary step. And related to this, fast injections. So historically, people have injected slowly and they thought that, giving a lot of pressure or putting a lot of pressure quickly was going to cause more pain. But in fact, it turns out that faster injections in the order of 1 or 2 seconds is better than slow injections that are basically taking 5 or more seconds to give the vaccine. And then another intervention that's particularly useful is having a competing tactile distraction. So usually this is achieved by applying some kind of vibrator or vibrating device on the opposite arm. And so this acts as a distractor, but possibly also activates tactile nerve cells, which then compete for the pain signal in the brain. So then kids are not really paying so much attention to the brain, to the pain, sorry, they're paying more attention to this tactile stimulation. Here on the right, I'm showing you the bottom right, an example of a commercially available product called the Buzzy that people may have heard of that can achieve this vibration. Now this slide shows an example of physical interventions. You see here in the picture a comfort position that can be used. So this will help children feel secure and to stay still, but at the same time can allow limbs to be exposed for vaccinations. So these typically allow children to feel more in control because kids are in upright positions, they're getting the support and hugs from a parent or caregiver, and it reduces their fear, which can reduce their pain. So you may yourself notice that if you're in a doctor's office or undergoing a procedure, if you're lying down, you feel more anxious than if you're sitting up. So having people sit up, including children, is a good way to prevent them from being more anxious. And comfort positions will vary depending on the child's age and level of fear. So if kids are younger and more scared, typically more hugging, more holding is involved. And as they get older, feel more independent and more confident, they will not require as much support from a parent. This slide summarizes the pharmacological interventions. We really only have one strategy that we can recommend that's good for all age groups, and that is topical anesthetics. Despite the fact that they don't penetrate entirely through the skin, they don't reach the depth of where the vaccine is given, they still reduce pain from both subcutaneous and intramuscular injections by about 50%. There's a few challenges to their use that have prevented them from being implemented in practice more widely than they are. Firstly, they cost money. Secondly, they require time to work. They take between 20 and 60 minutes, so you have to plan it. You have to put it on before you go to the clinic, or you have to have a waiting area where kids can have something to do while they're waiting for these to work. And also removal of the dressing can be challenging because there's a dressing that's usually applied on top of them to prevent them from being wiped away. But after about 30 minutes, people rip off the dressing and it actually hurts. So it's like ripping off a Band-Aid. So you're kind of undoing some of the reason you're putting it on, which is you're actually sometimes adding pain. So you need to know how to do this. And finally, you also need to really let people know what these drugs are going to achieve. So sometimes people talk about them as if they're going to cause kids not to feel anything or anyone to feel anything, but that's not actually true. They do not remove all sensation. You might still feel pressure or pushing, but it just won't hurt. So you have to let people know that. Otherwise, they walk away thinking, hey, you lied, I did feel something. And they have to be sure that they understand that they might have felt pressure, but didn't really hurt. So making that message clear is really important, especially for kids when you're trying to build trust and they think this is going to help them. So you have to give them a sense of what the experience is going to be like. Now, the final category of interventions is about psychological interventions. And this is the first of two slides I'm going to show you. And it's about interactions that we have with patients. So of course, during vaccinations, usually there's some kind of interaction going on between people, at least the immunizer and the patient. If it's a child, there may be siblings, there are parents around, and there's things everyone can probably think of situations where this has happened, where others in the room have helped make it a better experience or have actually made it worse. So there's certain things that we can let parents and others that are there know that are helpful to promote coping, but also some things they can do to make it worse. And so I have some examples here on the slide of some things that you shouldn't do and things you should do. So firstly, talking in a neutral way. Don't use words that people can find threatening. So don't talk about bee stings, don't talk about hurt and things that might make people more afraid. Also don't lie. So don't tell kids that it won't hurt or exactly how they're going to feel, because the truth is you don't know. pain is an individual experience. It's better just to describe how others may talk about the sensation and invite kids to tell you how they feel. And second, and then finally, don't put too much attention on the procedure. So sometimes kids are happily distracted, and then we say things like, oh, it'll be over soon. I know this is hard. And the way we deliver these messages, as well as the messages themselves, kind of cue the kid to pay more attention to the procedure and then get worried about it. So not to do things like that. So we want to instead speak in a neutral way, coach kids, and speak honestly and clearly. And that would be more helpful. Distraction is another type of psychological intervention. So basically it involves taking someone's attention away from the procedure, and it reduces pain. For it to be effective, though, you need to be careful about, the approach that you take for kids of different ages. And I'm showing you some examples on this slide about the types of things that work for kids of different ages. In general, kids are underutilized in their ability to help identify distractors that might be effective for them. And sometimes they're not even told that the procedure is going to happen. So they are not engaged in the process of picking something that might work for them. But instead, they should be told about the procedure ahead of time and given a chance to plan for it. And they can pick the things that work best for them. So this helps them to take control, to learn coping strategies, and then to build trust because they're part of this process. So keeping vaccinations a secret ahead of time to kids is definitely not something that works. And you can think yourself too. I mean, it's not nice to show up to a pop-up quiz or something where you haven't had a chance to study. So it's the same idea. We're more anxious when we're not prepared for something. So kids are the same. So we should prepare them ahead of time. And of course, the preparation is going to be different depending on how old the child is. Because if it's a young child and you tell them too much in advance, you may make them actually more scared. But depending on what this is, we can certainly tailor to the kids, and parents would know a lot about their kids and when they think the appropriate timing is. A final note I want to make about distraction is that oftentimes clinicians are looking to distraction to be the primary way to help kids cope during a procedure, but it's important to note that it's not really suitable for everyone. In fact, about a third of adults, when this has been studied, have said they don't want to be distracted during procedures, and they actually cope better if they can attend to the procedure and see what's going on. Because if you take their attention off it, they actually imagine things that are worse than what's really happening. So it's important to keep this in mind with kids too. We shouldn't be forcing them to look away, which a lot of immunizers do. They're well-intentioned, but actually that might make a kid more nervous because their natural tendency would be to want to look, and that would help them to cope better. So again, this means preparing people ahead of time and engaging them in the process and finding out what they want to do to make it a better experience. Now, in addition to these 4 Ps, we made some good practice recommendations in our guideline to address some of the overarching aspects which Dr. Allen was speaking about the environment and the setting, including minimizing fear-inducing visual and auditory cues, reducing the amount of time people wait because they build up their anxiety and their fear, especially if they're standing, providing privacy and comfort, and then responding and attending to the needs of individuals. We also made specific recommendations for people who have high levels of needle fear and for those who are prone to fainting. So for a high needle fear, people may actually be too afraid to go through the procedure, and they may require the help of a trained expert or therapist in anxiety disorders to help them to reduce this fear so that it's low enough so that they can actually have a procedure done. So the pain stuff that I've just talked to you about, all these interventions won't necessarily help get someone immunized if they are just too afraid. So that needs to be examined, and people need to have, obviously, the opportunity to know that it's okay to have a needle phobia and it's okay not to have the procedure because they have this phobia, but then to seek help to try to manage the phobia so that they can undergo the procedure. And then finally, here at the bottom, some people faint. Usually this is more common if you do have a phobia, but it can happen even if you don't. And there's a really easy strategy to prevent fainting. So we shouldn't be waiting for these things to happen, which can be very terrifying events for the person who faints. And we can proactively just tell people to tense large muscle groups like their legs when they're sitting. And this can prevent the precipitous fall in blood pressure that happens when people go on to faint. So now I'd like to turn very quickly to the fifth P of pain management, the process interventions. How do we get everybody to do what I said now that they should do? Well, the CARD system was designed to help address this knowledge to care gap. So basically the guideline tells us what to do and CARD tells us how to do it. It involves a series of steps and measures that health providers and institutions can employ before and during vaccinations. And cleverly, each letter of the word CARD stands for a category of interventions that anyone can play. So this is the healthcare provider providing the injection, the patient who's getting the injection, and this can all work together to try to improve the vaccination experience. So behind the scenes, the immunizers are doing things that I just mentioned about setting up the environment to reduce fear cues. They're injecting in a way that reduces pain. And from the patient's end, or from their point of view, they're controlling their own coping mechanisms or strategies. So whatever they have the power to influence. So they can use comfort interventions like wearing short sleeves shirts so that it's easy to access the arm and they don't get nervous because they need to disrobe. They can ask questions, things that are bothering them. Sometimes they can find out about things that they don't know if they ask, like, is there some treatment available to make this hurt less, to reduce part of the pain from the needle? They can learn about topical anesthetics. They can use relaxation techniques or find ways to be calmer. For a lot of people, this means being vaccinated in privacy, not in view of others. And then for those that want to be distracted, what are the sorts of things that they want to do? CARD to date is the only vaccination delivery framework that's been proven to improve attitudes and knowledge about vaccination fear and pain management, to improve vaccination safety by reducing these immunization stress-related responses, so pain, fear, dizziness, and fainting, and also to improve the vaccination experience, obviously not just for kids, but for the adults that are around them. So how do we integrate it? Firstly, we can teach parents about this so that they're prepared ahead of time, so that they're not nervous, and they can prepare their kids. So preparing kids, giving them with the information they need, helping them to plan their coping strategies, reminding everybody ahead of time so we know that this works to get people in on vaccination day, and they can also be reminded about things that they can bring to help them cope. Next, on the day of vaccination, we can reduce visual and auditory fear cues, help kids feel at ease. So there's ways to set up the clinic to try to do this, and ideally to have lots of private spaces, because kids typically get more anxious when viewing others get vaccinated. And then allow kids to play their cards. So during the injection, what choices can they make? Letting them make those choices instead of imposing coping choices on them or coping strategies on them. And then finally, communicating and using injection techniques that, again, promote coping rather than distress. So we're amassing numerous resources to help people to know how to do this. And we have a QR code as well. The QR code lands on a page on the internet that's called www.cardsystem.ca. But this also maps onto SickKids and maps onto Immunize Canada. So it doesn't matter almost which internet links you use, that you should end up in the same place. And just to very quickly show you the kinds of things that are on the website to help people, we have information for parents. So what does that look like? You can see here for a parent, pamphlets that can tell them how they play their cards. So how do they prepare themselves to have a good vaccination experience with their kids? And then how do they prepare their kids? Because before they prepare their kids, they prepare themselves. So then for their kids, they can talk to them about the vaccine, answer the questions that their kids have. They can also give their kids the pamphlets and the information sources that are age appropriate for children to learn about this system. We have resources that help parents to know how and what to say to kids. So if you look at this slide on the left side, you can probably relate to some of these things as being more helpful compared to things on the right side. that can make things worse. So teaching parents what the differences are between these different sort of ways of talking to kids and how that might be helpful. And then more information about comfort positions. So I showed you one of the pictures from this pamphlet, but we have other pictures, and you can see sort of all the different ways that people can be holding or supporting their kids, and how this might look different depending on how old a child is and possibly how afraid. And the idea is obviously not to restrain kids, so to avoid that as much as possible, because that increases distress a lot. We have information about topical anesthetics, which, as I said, can be very helpful, particularly for school-age kids who are very afraid of needles. And we have a resource for muscle tension. So how can we teach people about this so that we can prevent fainting? There's no reason why fainting has to happen when we have strategies that we can employ and be proactive about it. So I want to end here and just say that pain and fear, unfortunately, hurt vaccination. They don't just hurt kids, they actually hurt or undermine vaccination. But these adverse events are modifiable harms of vaccination. So we have guidance on what we can do. We have systems that tell us how we can do it. So now what we do is just have to get this information out there, try to embed this in our vaccination systems so that we can make vaccinations more positive. And so kids have good memories, they feel respected, they trust us because they know we're going to take care of their pain. And then they come back for their second dose and they go on to be champions of vaccination when they grow up. So I just wanted to end with a video that shows you what this looks like in action with somebody who's afraid of needles. Actually, this is an 11-year-old, I believe, or a 12-year-old who's getting vaccinated. And then maybe end with a testimonial if there's time of a parent. So let me just start this video and you can let me know if there's a problem with the audio.
Some kids get really nervous with vaccines and some kids aren't nervous at all. Let's say we had a scale of 0 to 3. 0 is going to be the lowest. Where would you say you are on that scale? 3. So that's pretty high. So you remember the card system that Kelly just went over with you as well. What kind of card are you going to play today that's going to help you with that?
Relax and distract.
Nice. What kind of things are you going to do to relax?
Deep breathing.
Right. Can you show me how you do that? Perfect. And what about distraction? Squishy. And I see you've brought a buddy with you too.
If the student brings their friend, ask the friend how they're going to help.
So you know what else can really help? If your buddy blows bubbles. Do you like bubbles? Bubbles can be fun. So I'm gonna have your buddy, what's your buddy's name?
Brooke.
Brooke. Hi, Brooke. Do you think you can blow some bubbles while I get things ready here? Deep breath, blow. You're doing extremely well. One more, honey, and then you're done. Good job. You're completely done. What do you think? You did really, really well. And thanks, Brooke, for helping out. Some kids get really nervous with vaccines.
My name is Tani, and my daughter just had her grade 7 vaccines. Well, she has been very nervous about immunizations. She has been for many years. And, you know, I told her about that there might be the card system. So we were just, you know, easing our way, working into trying something that we were hoping would be helpful to get her through the immunizations. So when my daughter came home from school that day, I wasn't sure how the reaction would be, but when she came home, I could tell by the smile on her face, she was calm, she was relaxed. I knew that it went well even before she even said anything, and when she did tell me how wonderful it did go, I was just so relieved and I was so proud of her, and I could tell that she was proud of herself as well.
And finally, just some resources in case anyone's interested. The information that I spoke to today is mostly contained in these resources. So I'm going to stop here and thank you for your attention.
Thank you so very much, Anna and Upton, for this illuminating presentation. We are now open for a short period of questions and answers before we go into the second part. Somebody has just posted an observation that in that video, one could hardly notice when the injection even went in, which testifies to how well it was done. So Anna, I noticed that she didn't even say when she was going to do the injection.
Yeah, and that's a great point that you picked up. So that's another thing is a lot of us, we were trained to do things a certain way and we have our habits. And, people might do things like say, okay, I'm going to count down or 3, 2, 1, here I go. And that may work for some people, but for other people, it may actually make them very afraid. So a part of CARD, that preparation piece is for the immunizer to ask the kids specifically, how do you want us to do this? Do you want me to talk to you, do the procedure? Do you want me to, give you a warning ahead of time? How do you want this to be? And then the kid can give their particular preferences. And then the immunizer goes along with those preferences. So that's part of that working together to do something which makes that child feel very empowered. But nurses need to have a backup because sometimes kids, they can't do it or something happens. So nurses need to sort of, how would I say, give the parameters for when I'm going to try to do it that way. But if it doesn't work that way, is it okay if we can try something I suggest? So I hope that helps answer that. But yeah, so some of these things, they may be subtle, Isaac, but actually to the user or to the child, it's a completely different experience when they're treated in this respectful way, where they're asked about their preferences and the appointment goes that way.
Right. No, that's great. Upton, so you were talking from the regulator's point of view. From what you've heard of what happened with the FDA and its decision on the Pfizer vaccine for the 5 to 11, were there any sticky points that came up at all, which people ought to be aware of and might help with promoting vaccines for these kids?
Yeah, thanks, Isaac. To be honest with you, the main sticky point is myocarditis. It's definitely a concern. The good thing, fortunate thing, is that it's rare. And as the kids get younger, it becomes less likely. And I think the graphs that I showed you bring that point out. But somebody might ask, well, what is it about the kid who is under 12 versus older kids? And I had a closer look at that, Isaac. And let me answer that question, if you will allow me. Let me answer that question by showing you one slide.
Okay.
It'll be very brief. Let me show you this one slide. Do you see that slide, Isaac?
Yes.
So these are some animal studies, and they looked at the effect of sex hormones on Coxsackie B3-induced myocarditis. And essentially, we had female animals, male animals, and then then they gave them estrogens or testosterone. And basically, FV is the female animals who had virus-induced myocarditis. And you can see the percentage of the myocardium, heart tissue that's been inflamed. Then when you give them estrogen, it's, it's a little bit different. When you give them testosterone, you can see more myocardium inflamed. And then these are females. On the male side, males, higher rates of myocardial inflammation. When you give the males testosterone, it drives up the rate of inflamed myocardium. And when you give them estrogens, it actually is protective. And so essentially, this is pointing to a potential hormonal effect. And so the pre-pubertal kids, Isaac, are likely to have a low myocarditis signal.
Right. No, that is very, very reassuring. There's a questioner asking you to elaborate a little bit about the process of approval for children by Health Canada for the 5 to 11.
Well, Health Canada will go through the same process that FDA is going through, and it's no different. And one might ask the question, well, why is it slower? And And, you know, I don't think it's necessarily that Health Canada is being any more careful than FDA. It's just that there might be additional questions that Health Canada is asking that will come out in the approval and in the recommendations. Things like, for example, the interval between the doses. Things like, well, what does one do with the person who got a dose at one age band and then they got older? You know, do they get a second dose at a higher, you know, so if the 11-year-old who turns 12, when they turn 12, do they get the dose that they got when they're 11, or do they get a new dose? So those are the things that Health Canada and NACI are looking at. But it's the same very careful process of looking at the data that Health Canada is going through as FDA would have gone through.
Right. Question for Anna. Is there a card system for adults?
Yeah, that's a great question. Absolutely. It's the same. So the only difference, it's the same framework, works for everybody, no matter how old you are. The only differences are the options. And, you know, so under comfort, maybe there's things that kids would pick that adults wouldn't. Kids might bring a blanket or a stuffy animal to feel comfortable. An adult might bring a support person to sit beside them. Asking questions. Kids typically are afraid of the needle, as Upton said. So they're going to ask questions like, how much does this hurt? And what are you going to do to help me? Adults may have other questions. So it's a generic system, and we actually have resources for adults as well. And by the way, CAMH, the Center for Addiction and Mental Health, uses CARD in their vaccine clinics. So they've embedded CARD in all the clinics that they use. So all the adults are getting this information at the booking. And when they come in, they're given a checklist that says, hey, how do you want us to approach this visit? And so this is where they can tick off, I want privacy, I want a support person. I don't want you to say anything during the appointment, you know, whatever those preferences are. So that's a great question, yeah.
Based on this, it's surprising that our public health system haven't promoted it as much.
Yeah, so we're trying to get it out there. So this is a great opportunity, as I said, for me to be here, Isaac, and for everyone who's on the call, maybe to reach out to the you know, their communities and let them know about this, so we can try to make it be embedded in the process. As WHO said when we brought the guidelines to them, which they endorsed in 2015, they said pain mitigation is part of good immunization practice. It's not a thing maybe nice to do. It is integral to our process. And we can do this stuff. It doesn't cost any money, right? It's just a different way of doing things, and we can do it. So thanks for that question.
Thank you very much. At this point, I think we are ready to roll into the second part of the session, where we're going to have a panel, and some few others are going to join the panel, and I will let them introduce themselves briefly. Michelle, why don't you start the ball rolling?
Hello, everybody. I am Michelle Barton Forbes from London Health Sciences Centre. I'm a pediatric infectious disease doctor, chief of infectious disease at LHSC, and I have been part of setting up a Southwest Ontario-wide COVID virtual clinic where we see children with pediatric COVID. It's really run by my nurse practitioner, Leah Etier, currently, and we see patients with long COVID as well.
Right, thank you. Danielle.
Hi, I'm Danielle. I'm a pediatric hospital medicine fellow at SickKids. I have a background in virology and infectious disease, and I currently work in the COVID vaccine hesitancy clinic at SickKids, providing information for parents and patients that call regarding the COVID-19 vaccine in children.
Thank you. Pierre-Philippe.
Hi, thank you very much, Isaac. Very nice to see you. Very nice to see everyone. So my name is Pierre-Philippe. I'm a clinical and research fellow in pediatric infectious diseases here at SickKids. And I'm also doing a master's degree at IHPME at U of T with all sorts of projects related to COVID-19 vaccination in children. And I've taken an active role at the special immunization clinic at SickKids, and as well as supporting some vaccine-related initiatives, such as the vaccine consult line that Daniel has spoken about. So very nice to be here.
So as we begin this session, if you have any questions, just post them on the chat and we can take them along. So Pierre-Philippe, I will start with you. The big elephant in the room is myocarditis. That is the one that everyone is talking about. What has been the experience of SickKids so far?
Thank you for that question, Isaac. And it is true that it's a very important topic, and it's a question on which we've had quite a lot of interest, first of all, with respect to surveillance mechanisms, but second of all, to have a good system and very good partnership with our cardiologists to support these referrals and to see these patients and to see what's happening with these patients. So what I would say is that so far, we did receive a fair amount of referral for patients in that situation with either pericarditis or myocarditis. I would say that it is a spectrum of illness that ranges from a very mild illness, so patients who present with clinical symptoms of pericarditis, so chest pain, shortness of breath, but with a completely normal workup, so completely normal heart function, normal troponins, normal ECG. So it ranges from very mild symptoms that will be self-resolved within a matter of days, plus minus the use of anti-inflammatory drugs, to a more severe presentation that may require hospitalization. However, these more severe presentation with hospitalization and decreased heart function are extremely rare. And the bulk of the patients that we've been seeing fall within this continuum of a mild to moderate illness, with most of the patients that we're seeing in pediatrics not requiring hospitalization even. So they are seen in the emergency department, they are found to have a raise in their troponins, plus minus some ECG changes, a normal heart echo, and they are sent home with anti-inflammatory drugs. And in a matter of days, they've been doing well and back to their baselines. With respect to the patients that we've been seeing at the special immunization clinic, now it's been many months since we've started to see them. So starting in about May, June, once this signal was picked up, and 95% of the patients that we've been seeing are back to their baseline completely, including with normal troponins, normal ECG, and normal heart function, with a very tiny subset of patients still having very mild symptoms. So what I would say, the bottom line of the message from my experience so far is that yes, there is a signal of myocarditis, pericarditis, myopericarditis following immunization, but that the vast majority of these episodes have been mild and self-resolved, plus minus with the use of anti-inflammatory drugs.
So, Jean-Philippe, for the physicians in the community, what should they be doing if they encounter somebody who has chest pain?
I think what is important for physicians in the community to know is that if patients do experience chest pain after immunization, it's really important to seek healthcare at the times that they present symptoms. And that's truly important because we have received a fair amount of referral as well for patients, for example, who have experienced chest pain after their first dose of the vaccine and question around eligibility to receive the second dose of the vaccine. And in the future, we're going to consider booster doses for, well, it's going to trickle down from older individuals to eventually younger individuals. But some patients have mentioned having symptoms, but did not consult with their symptoms. So it's really hard to say, were these symptoms truly associated with this condition of either, well, the continuum of severity associated with myopericarditis following immunization, or was this anxiety, for example? Was this something else? And it's really important to be seen by a physician to assess, could there be another cause explaining these symptoms first of all? And second of all, if it is due to the immunization, what's the extent of the severity? Because this will inform decisions around future doses of the vaccine, especially if it happens after the first dose.
Thank you. So, Michelle, I know that the risk-benefit ratio balance for kids is different for adults. So in your work, how are you handling that and how are you presenting that to families?
a very good question, Isaac. And that actually is a question that parents put forward regularly, because in their mind, in their eyes, they see that the COVID has devastated adults and caused high mortality, high morbidity. And we look and we see children getting COVID, and a lot of them are not really admitted. Some of them are mild or asymptomatic. So then what is the rationale for giving a vaccine that could potentially have some risks, and why would we bother? So I think what Dr. Allen spoke to was very, if you noticed what he said, he spoke to the acute morbidity and long-term morbidity of COVID, but he also addressed the population effects and the transmission effects. And I would say to you, even as a parent, my concern would be, I always say to parents, none of us wants to see a child suffer. No one wants to see a child go through a critical illness or even have the potential to end up from a fatality. Fortunately, fatalities are not often. But far beyond the morbidity and the potential mortality related to rare things like MIS-C and even acute COVID is the long COVID. The long COVID is really it's an evolving situation as it relates to pediatrics. And it is a challenging situation because there's not much that you can do. It's a supportive illness, but during that period, you're watching your child suffer. I put it to you, it's not easy. We are seeing more and more children coming in with these vague problems like insomnia, emotional disturbances, breathing difficulties. We're seeing children who were fit and athletic not being able to function competitively. And we're even seeing distressing things like tinnitus. I saw one child and she had such marked tinnitus. It was distressing to the family, and there's not much that you can do. So if it is that long COVID affects 10% of children, let's say 10%, it's variable, we're not sure. Some literature is suggesting higher, some literature is suggesting lower. I even saw one literature going as far as even extrapolating that it could be even reaching to 40%. I don't know if we have evidence for that, but what I do know is that even if we take it that it's 2 to 10% of children who will end up with this is huge, because we have large amounts of children. It can happen even after asymptomatic infection. So if it can happen after asymptomatic infection, and we could end up with our children having brain fog and long-term brain changes. Some of the imaging is showing that there's changes on the MRI in the brain, and we don't know how long that's going to last. To me, that in itself is huge, that I shut this thing down and don't expose my child to unnecessary long-term effects, which I don't even know where they're going. And until we know that there's a major adverse event that flags after the vaccine rolls out, I would say the benefits far outweigh the risks. Not to mention the trauma that our children have gone through in terms of disruption to school, their social events, their sporting, the anxiety that they feel not being able to interact with their grandparents and the elderly folks in their circle. This is huge.
Thanks for putting it so clearly. So Danielle, you've had a very good experience in promoting vaccine confidence. Children have been traditionally the recipients of many vaccines. What are some pearls that you've learned from there that you think will be useful as we roll out COVID vaccine administration to the 5 and 11-year-olds?
So I think it's just the reassurance that vaccines are safe. Vaccines have historically been very safe. The vaccine that we are currently talking about with the COVID-19 is overall very safe. And I think it's providing that reassurance to the families that, they're scared. This is new. I hear that a lot. This is a new vaccine and we don't have the data. We actually have really good data to show us from what we know right now, this vaccine is very safe based on the timeline. And that's consistent with vaccines of the past as well. And I think just kind of reassuring families that we've got to this point, and their children have been vaccinated and have done very well. And there's no reason for us to believe that things would be different. Of course, there's rare side effects that we've already discussed, but overall, they're very safe, and providing that reassurance. I think the main thing that I've encountered is when you're talking to parents, they just want to do the best thing for their kids. And sometimes there are reservations because they believe that they're doing that. And so I think discussing with them the evidence that we have, the data, and then just providing that reassurance is very helpful for them going forward.
And what about reporting any adverse events? Does that help if they know how to do that? And
I haven't had a lot of questions about that. It's more about is this a possibility and kind of what are my risks for that? But I do believe that that would be helpful in terms of reporting those events as well. And I think a majority of the questions are just coming from parents that do want to do the right thing. And they just want us to say that these things are rare, but having a procedure in place for where they know where to go in terms of reporting would be absolutely helpful as well.
Right. So, Upton, there's been a comment about the data that was submitted to the FDA about this Pfizer study. It looks as though racialized communities were underrepresented compared with the adult study. How do you think they should be handled? Because some people might point it out.
Yeah, no, it's a really great question. There clearly is a need for more participants from racialized communities to be involved in these studies. That's number one. But also what we can do is to ensure that when folks from racialized communities are vaccinated, we create a framework around them that includes monitoring for any adverse events, so that in the post-marketing phase, the surveillance phase, if there are any signals, we can say that those signals were looked at not only in the white population, but was also looked at in racialized communities. And so there are a number of folks, myself and Michelle and others, Isaac, who are involved in Cheryl Prescott, such work to try to ensure that individuals are plugged into studies that will provide information that goes back directly to them, and also benefits the community at large by providing data that are derived from their communities and not just extrapolated from other populations.
Right. No, thank you very much. And now back to CARD. So just be on the pragmatic side, community vaccination programs are going to open up in the near future. Which aspects of CARD do you think can be easily implementable? Do people need training, or is it something that is easy to use, and which maybe one or two areas will you want to emphasize?
Yeah, so that's a great question. So so the things that I would say are the most important are, one, preparing the families and the kids ahead of time. So we need to get this to be part of the booking. So this is part of getting people prepared, having the confidence, having their questions addressed, and they know when they walk in, like I said, that someone's going to take care of them and their child, right? So they're going to be taking care of, the kid knows that we care about them and their fear and their pain. So that's one, is educate everyone before they come. And two, the surrounding needs to be appropriate for how we expect children to also react to the situation. So if we can minimize these large open spaces like the traditional, we're going to vaccinate everybody in the gym at school, which leads to a lot of terror. And yes, it's true, some kids will be benefited by watching other people go through the procedure first, but in general, the risk of causing a fear contagion usually is higher, or can lead to kind of more negativity in the long term compared to the kids that you end up helping. So I would say build these private spaces, however, with cubicles or something where families can be together in a place and supported. And then, surrounding that, again, is kid friendly. So like nice posters, card poster up there, some distraction things that are easy in case kids don't have them, to be able to operationalize some of the things that we want to do. But I think those are the most important things. And, if the immunizer themselves is engaging with kids at their level, the things we always tell people is look at the kid's face, look at them in the eyes, address them specifically and give them a smile. Do these connections, these connection pieces that make them feel like you're going to help them. Those are, I think, the most important things, and they're easy to do. We just need to try to help with the community setting. So if people are setting up these things, I would say, let's talk about a way that we can show everybody to do this that can be done more broadly so that everyone will have a good time.
So Anna, based on what you said, I think what is going to emanate from what we're doing here is that there'll be communities that will set up opportunities to vaccinate children. Perhaps we should have a way in which they can receive the support they need from experts like you and other entities, so that this becomes an integral part of rolling it out upfront, rather than sort of tackling issues that occur.
Yeah, and we've got it right. And, there's opportunities also to revisit, I want to say, some of the things that we do that are not evidence-based. So, how we keep talking about following the science, following the evidence in this pandemic. This is a perfect example where we need to follow the science. We know this is helpful. And we also maybe can take away some of the stuff that's not evidence-based that might make kids afraid, like alcohol swabs. So we do that. We continue to do that in Canada. Swab the skin before we give injections. That is not evidence-based. The WHO has made, a statement on this a number of years ago. And recently there was an editorial published in Vaccine by one of the prominent researchers in this space saying, why don't we take this away? And we know other countries don't do it, right? So maybe Canada can also use this opportunity as a way to say, okay, let's get up to date with the evidence and let's make this and this also helps make it a better experience for people who are afraid, because that's one of the steps of the procedure that, escalates your anxiety, adds time, and just makes it worse. So thanks, Isaac. I'd be happy to help brainstorm with people, things that are feasible. One thing I do want to note is, we don't have to be perfect, and we won't be perfect. No. But even just trying some little things are going to be better than not doing anything at all. So I want to make that point too.
Right.
Isaac, I just wanted to make a point. With the rollout of this vaccine strategy, if Health Canada, or when Health Canada approves, I think as pediatric caregivers, we have to be sensitive to the fact that the 5 to 11 year group is a different age group from the 12 and older, and rolling out mass vaccination at pharmacies may not be a good strategy, where children are screaming. And I think we have to be sensitive and have children-friendly approaches to this strategy. And that I think I've heard people just talking about mass rollout in pharmacies, but I don't know if it has that pediatric layer lens to it.
Yeah. So they are not just small adults. They need a particular sort of focus plan and attention. It seems to me that it will require a little more organizing and planning, and a little more resources to really establish the right environment for children.
Yes.
And I wonder whether our public health system is recognizing that.
Yeah. So can I make a comment, Michelle? You've just landed on something I'm trying to work on, is which to support pharmacists. So people may know that pharmacists in Ontario also were delegated the ability to vaccinate kids with the flu vaccine as young as 2 this year for the first time. So it used to be kids 5 or older or over 5, and now it's been reduced to 2 years and up. And this has caused a lot of anxiety for pharmacists because, as you say, the pharmacy spaces were never designed for patient care to begin with. They've been kind of retrofitted, to have these counseling rooms. And now on top of that, you're asking them to vaccinate kids. And somehow the processes need to be changed for this. At the very least, I would say, again, a simple measure, the appointments need to be 20 minutes instead of 5 minutes. There's simple things that we could tell people so that even that rushing aspect of it, which increases anxiety for everybody, they take that away. So, we got to work on it. I'm not sure that that's going to go away now that it's out there, but I feel like, as you do, we need to prepare the immunizers because it's not just about the experience of the patients, it's also about themselves. And there's a lot of burnout in pharmacy, like in other healthcare professions. And we need to keep these guys strong, confident, and, being able to, again, have trusting relationships with the families and not letting them down.
So Anna, do you know whether there's a pushback from the pharmacy community?
Yeah, so some are, but it's almost like you don't have a choice. And deep down inside, like the other healthcare providers, pharmacists want to do the right thing. They want to help in the pandemic. So they're having these ethical conflicts, right? About if I do this, it's kind of what I want, but kind of I'm not doing this other thing. So this is happening all the time. And I would say it's continuing to happen, and it's probably further magnified now with children getting vaccinated, because again, they don't want to walk away. They feel this is a part of their responsibility to keep the community healthy, but they don't have the support from, say, the chain, the stores, or the infrastructure to be able to control this process and implement all this stuff on their own.
Pierre.
Thank you, Isaac. I think this discussion is really fascinating, and these are really important questions with respect to the rollout in 5 to 11 years old. And certainly there can be some experiences gathered from the rollout in adults that we can use, and there's been some headwinds to this pandemic. For example, the use of the COVAX platform, which is like a central electronic repository of all doses of vaccine that are being administered. So this is fantastic that now we have such tools based on the rollout in adults. But I'm just hopeful that stakeholders and public health units and instances will not only take into account the experience gathered from the adult rollout of COVID vaccines, but also from the large experience in rolling out other vaccines in children for a very long time. And there is very good data on what are the best model for delivery for children in this age group, and certainly a multi-pronged approach, including the use of school-based immunization programs, would be very good for equity purposes, because certainly to reach some of the children that are in lower SES strata, having them booked appointments through their primary care physician. First of all, do they have good access to their primary care physicians? Second of all, do they know to go in pharmacies? So there would be some headwinds in using school-based platforms for the delivery of vaccines, but I think it's important to speak to all stakeholders and have various modes of delivery to make sure that we can reach all communities at once.
Yeah, Upton.
Yeah, I think perhaps connected somewhat with what Pierre said, Isaac, is the importance of ensuring that we approach things through an equity lens, number one. But also be sensitive to the communication on prioritization, in the sense that one doesn't want for the use of the word priority or prioritization to be misinterpreted. And so there are a number of us who feel that perhaps we should not use words like priority or prioritization when it comes to vaccinating the children, because that could be misunderstood.
Yeah.
And so rather to focus on, as Pierre said, getting vaccines to everyone at the same time, and ensuring that the right supports are provided to specific communities so that everybody can be on the same level playing field. And so I think articulating it that way, I think is really great. And I heard, Councillor Joe Cressy on the radio last night, and he spoke to that, to getting the supports to neighborhoods, as opposed to focusing on priority. And so I hope we continue along that pathway. Isaac, one thing I should mention is that, because I've heard people ask this, how might we work to ensure that we have enough human resources to take care of children in these various vaccination settings? And I think it's something that we need to work on to get vaccinators, people who are used to working with children. We need to figure out how to make that happen.
Yes, and that mobilization will have to be done carefully. It will be slower because we need more time for kids. The setting has to be different. It has to be child-friendly. People have to be knowledgeable about how to handle children. So this will be slightly different from the way the adult rollout was. And we have to make our voices heard so that our policymakers and public health system makes those resources available. So human resource will be key. Right. So one final comment before we finish. Any one of you can comment. Because our STEP initiative is to reduce inequities as well, and to ensure that vaccine confidence is promoted across the board. What have we learned from the rollout in the adult vaccination that you think we should take into vaccinating the children?
I can comment. I think that I've seen, and I'm just going to comment on the community setting because there are different models, obviously. But I've seen the excellent work done by some of the folks who are on the call today in the community settings. And it's really clear that for a number of racialized communities, what works is an environment where it's not a vaccination event. It's an event that takes care of vaccination. There's music, and there's ice cream, and there's a clown, and you can get your blood pressure checked, and you get a blood sugar checked. And so it can be a family event, and I think that is something that we should take into account, because that really seemed to have worked with the adult mass vaccination rollout in certain communities.
Many thanks. On that note, we'll bring this to an end. Please don't forget to provide your evaluations. It's been posted on the chat where to provide your evaluations, because these are very useful for us as we roll out the other sessions in this STEP program. Many thanks for spending your 1.5 hours with us this afternoon.
Thank you.
Have a good day. Bye-bye.
Bye-bye.
Thank
Thank
you.
you. Have a good
Have
day.
a great day.